Trauma resuscitation has moved away from crystalloid fluids and toward early, balanced 1-to-1-to-1 component therapy, an equal ratio of red blood cells, plasma, and platelets. Executing this protocol inside a vibrating helicopter or the back of a moving ambulance is a logistical nightmare. It means managing multiple bags, complex warming lines, and limited IV access on a patient who is actively bleeding to death. Low-titer O whole blood, or LTOW, is type O blood containing low levels of anti-A and anti-B antibodies. It streamlines this logistical chaos by combining red cells, plasma, and cold-stored platelets into a single administrable unit. Military data and retrospective observational studies have shown promise. This data drove a significant push for civilian emergency medical services and air ambulances to adopt pre-hospital whole blood protocols. Despite the physiological elegance of a single bag, the critical care community has lacked a high-quality, randomized civilian trial to prove whole blood actually improves survival. The NHAM's SWiFT trial, Study of Whole Blood in Frontline Trauma, was designed as the pragmatic Phase 3 randomized controlled trial to settle this debate. 10 UK air ambulance services randomly assigned major trauma patients to receive either whole blood or standard care before hospital arrival. The intervention limit was strict. Patients received a maximum of exactly 2 units of their assigned treatment in the field. Standard care, in the context of this specific trial, meant up to 2 units of packed red cells and 2 units of plasma. We are going to dissect the SWiFT data to understand exactly why up to 2 units of pre-hospital whole blood failed to demonstrate clinical superiority over standard components. The trial enrolled 942 patients based purely on clinical gestalt, a provider's immediate judgment that a patient had life-threatening hemorrhage. The modified intention-to-treat analysis strictly applied exclusion criteria, removing patients already in traumatic cardiac arrest. Filtering out non-salvageable patients ensures the data reflects a survivable cohort, preventing guaranteed fatalities from diluting the efficacy signal. This chart displays the baseline injury characteristics of the remaining cohort. It shows a predominance of blunt trauma and a high median injury severity score of 33, well above the threshold of 15 that indicates major trauma. With a median score of 33 and non-survivable cardiac arrests filtered out, this cohort was the optimal testing ground for whole blood to prove its worth. The trial's composite primary outcome was measured against 2 endpoints: death from any cause, or the need for a massive transfusion within 24 hours of randomization. A massive transfusion is defined as the administration of 10 or more units of any blood components. In the whole blood group, exactly 48.7% of participants hit this primary endpoint. In the standard care group, 47.7% hit the endpoint. This resulted in a relative risk of 1.02 and a p-value of 0.84. A statistical dead heat. Every secondary mortality endpoint measured at 6 hours, 24 hours, 30 days, and 90 days mirrored this exact null result. The addition of cold-stored platelets inside a pre-hospital whole blood bag did not reduce early mortality or halt massive hemorrhage compared to red blood cells and plasma alone. There was one physiological metric where the 2 treatment arms diverged: the coagulation labs drawn upon arrival at the trauma bay. A significantly higher percentage of the whole blood cohort arrived with a prothrombin time, or PT, above the normal range compared to standard care, 40.7% versus 30.5%. PT measures how long it takes for blood to clot. The underlying mechanism causing this lab difference relates to the hidden variable of blood storage times. Standard care utilized thawed or lyophilized plasma that was typically less than 5 days old. The whole blood units were stored at 4 degrees Celsius for up to 21 days. Older plasma in the whole blood units contained degraded clotting factors. This in vitro degradation directly resulted in transiently worse PT labs on arrival for those patients. This storage artifact spiked the initial PT labs, but it did not translate into an increase in massive transfusion requirements or mortality. It is a laboratory curiosity rather than a clinical failure. The lack of superiority requires us to look at a crucial limitation of the trial's pre-hospital setting: the strict physiological dose limit. Due to flight weight and space constraints, participants received a maximum of exactly 2 IV blood bags of whole blood, roughly 940 milliliters. A trauma patient with an injury severity score of 33 who is actively exsanguinating carries a massive physiological debt. For a patient with this level of injury, 2 units of whole blood represents a fraction of their total blood volume loss. This volume may be too small to exert the specific clotting advantages of whole blood before the patient reaches the trauma bay. These data points have direct implications for the emergency departments and EMS agencies making protocol decisions today. For pre-hospital protocols and initial massive transfusion activations, the SWiFT trial demonstrates that whole blood and component therapy are equivalent in clinical efficacy at low doses. Medical directors should no longer justify the adoption of whole blood to hospital administration by promising a significant survival benefit. The value of whole blood is operational. It requires 1 line instead of 2, speeds up administration times, and reduces cognitive load and transfusion errors for providers operating under extreme stress. Whole blood streamlines pre-hospital operations under extreme stress. While it is an equivalent alternative to component therapy, its primary advantage lies in its delivery, not in a superior survival signal.